there we go, are arteriosclerosis and hypertension are the main causes of chronic kidney failure. So this is hardening of the arteries and arterioles in the kidney, and you can imagine the effect that would have on kidney function. A small group of diseases called cystic diseases that we're not going to talk about, but basically you get dilation of the collecting duct of the tubules and formation of cysts within the kidney. Many, many people on autopsy have small cysts in the kidney that produce no symptoms. But there are some people with inherited disorders called polycystic kidney disease where they develop a ton of cysts. And that actually takes up most of their abdominal cavity because their kidneys become so enlarged from all of these cysts. Over time, the cysts take over the normal space within the kidney, and the kidney, they end up going through kidney failure. There are tumors of the kidney, and then, of course, you can have obstructions. Usually these are in the ureters, which decrease flow out of the kidneys of the urinary filtrate, and that can back up and either lead to bacterial infections or just increased pressure within the kidneys and the inability to filter anymore. So here's a critical thinking question for you. If a person has renal artery thrombosis, and the renal arteries are the arteries coming off from the abdominal aorta, so they're the main big arteries feeding the kidneys. So if you have renal artery thrombosis, which part of the nephron will be most affected? And you can discuss with each other. How many people think A? How many people think B? How many people think C? And D? Everybody's shy. So now that you know the answer, see if you can come up with a reason. Why would it be the ascending loop of Henle? Any thoughts?
Is that because of the pressure there that regulates the nutrient concentration back and forth gets affected?
It's not about necessarily the pressure of the filtrate. You mean the pressure of the fluid in the? So the pressure does change, and that's an important part of it. Does anybody remember why how that mechanism works? What's that? There are sodium pumps on the ascending loop. That's another important part. So on the ascending loop of Henle, there are the sodium pumps to actively concentrate. You get passive concentration on the descending loop and active concentration on the ascending loop. So the renal tubule cells in the ascending loop are metabolically very active. There's a lot of pressure as you dip down through that ascending loop because of the concentration gradient that's set up. So if you put those two things together, what happens with renal artery thrombosis? What's happening to the kidney as a whole? Ischemia, right? And remember that ischemia is going to affect the metabolically active tissue first. So in the glomerulus, there's a lot of capillaries, but it's actually a passive filtration system. The blood coming in is going to filter across, whereas you have a lot of active pumps in the renal tubules. The ascending loop of Henle, in addition to being metabolically active, here's your little nephron, and the loops come down into the medulla. And remember that the medulla actually has reduced blood flow as well. So most of your capillaries are right around the tubules up here. And as you go down, there's less blood flow to that area. You're at the distal most part of the capillaries when it goes into the descending loop of Henle. So for two reasons, it's metabolically active, and it's at the end, the distal most part of the blood supply region. That's why it's most prone to ischemia. And that's similar to when we were talking about heart attack. And remember that the part to get a transmural infarct that affects the whole part of it, you start right at the subendothelial or subcardium, endocardium layer, and then the wave of ischemia progresses as you get farther and farther from the blood supply. So it's a similar mechanism here. The distal most regions are always most affected by ischemia. Okay, so you won't see any questions this hard on the exam. It was really just to stimulate your thinking. This question actually I took from a medical school board exam. So this is the kind of stuff that you'll be learning and tested on to get if you do go to medical school eventually. And there's similar style of questions on the NCLEX and other of the nursing exams. Okay. Everybody's brain pumping and working now? A few terms that you should be aware of when we're talking about kidney diseases, because these are ways of describing the symptoms or the function of the kidneys. So hematuria, what's that? Blood in the urine. Most of the time, if you see blood in your urine, you'll go straight to the emergency room. That's a clear sign that something is wrong. You should not see blood in the urine. What is proteinuria then? Protein in the urine. And that's much more common and harder to detect. But you should not have any protein in your urine. Protein should not be filtered into the urinary space to begin with. And any amino acids that are should be reabsorbed. So, oliguria, any idea? What's that? Oligo meaning small. So oliguria is decreased urine output, small urine output. Often a sign that the kidneys are starting to fail. Pyuria. Pus in the urine. Also, sometimes you just measure white blood cells. So it's a sign of infection. Azotemia. So azotemia means you have an increase in blood, urea, nitrogen, and also creatinine. And these are two chemicals that are normally filtered out by the kidneys. And so when the kidneys aren't working, urea and creatinine increase in the blood because they're not being filtered out. So by measuring the relative amount of BUN or creatinine, we get an indication of the glomerular filtration rate, or the rate at which the kidneys are filtering the blood. So GFR, glomerular filtration rate, is used clinically synonymous with the function of the kidneys. So we measure GFR to measure kidney function. No, it is pretty uniform across people. I mean, there's a range for sure, but it's a pretty steady range, enough that it is clinically significant when the GFR goes up or down, mostly down. And along with that, so there is a range for normal. And then people with chronic kidney disease, the GFR gradually decreases. And so it becomes the new normal kind of thing. And so you're tracking that change over time as an indication of when you need to put somebody on dialysis, which is end-stage kidney disease. Thank you for closing that door. So let's start out talking about glomerular diseases. So again, the glomerulus, yes?
What was the last one on the last slide?
Blood urea nitrogen. It's a measure of urea. Urea nitrogen is a metabolic waste product that is filtered out by the kidney. So if the kidney is not filtering, it's not doing its job, then you get an increase of blood urea nitrogen, that urea nitrogen in the blood. So if your kidney is working, that BUN level should be very low. You're peeing out all of your urea. If your kidney stops working, then your BUN goes up. Yes?
How long can we stay on dialysis for?
People can be on dialysis for years, 7, 8, 10 years. Once you've reached end-stage kidney disease, you have to be on dialysis until you get a kidney transplant. And the waiting list for kidney transplants is so long that unless you have a family member, you can be on dialysis for a very long time. And it depends on the type of disease. If you have a progressive kidney disease, then you may need more and more frequent dialysis, and it might get to a point where you can't keep up. You're basically having to stay in the hospital or a dialysis unit full time. Whereas some people, they may need dialysis only a couple times a week, and then over time that might get more and more frequent. But you can be on dialysis for quite a long time. And what dialysis is doing is basically the job of the kidneys. It's filtering out these metabolic waste products. The problem is dialysis can't do all of the functions of the kidney. So one of the functions of the kidney is to take out metabolic waste, like urea. Creatinine is a breakdown product of muscle. So what else does the kidney do? It regulates blood pressure. So that renin-angiotensin system, renin is a hormone produced by the kidneys to regulate blood pressure. So a person on dialysis is losing that control of blood pressure, and they often have to be on blood pressure medication as well. What else? So the things that dialysis can do is regulate salt, regulate acid, and regulate or get rid of metabolic waste. It can't do the blood pressure. And then the other problem is parathyroid hormone is regulated by calcitonin, which is secreted, or it's controlled by the kidneys. And so calcium regulation depends on the kidneys as well. So we have a lot of hormonal influences in the kidney in addition to just the filtration functions. Okay, so glomerular diseases are affecting the glomerulus and not the rest of the kidney. And the glomerulus is where the liquid from the blood, the plasma, filters into the urinary space. And we divide glomerular diseases into primary and secondary, although the mechanisms tend to overlap. Primary glomerular diseases affect only the kidney, or primarily the kidney. There may be other manifestations, but it's the kidney that's the main focus of that problem, and then other symptoms might be downstream of that. Whereas secondary glomerular diseases are the glomeruli are affected by some other problem going on in the body. So diabetes can affect the glomeruli, often because you have high blood sugar and it causes endothelial damage to those capillaries in the glomerulus. Lupus, which is an autoimmune disease that you produce autoantibodies to a lot of the different proteins or DNA in the body, and those immune complexes or antibodies can get deposited in the kidneys and cause glomerular disease. And then the bottom one here that you can't see on is Goodpasture syndrome. So Goodpasture syndrome, we talked about a little bit. It's anti-glomerular basement membrane. So this is an autoimmune disease. That has anti-glomerular basement membrane. And we're going to see this again. Antibodies. So let's talk about the structure of the glomerulus to understand how it gets damaged. So on the outside, the capsule is made up of epithelial cells. And these epithelial cells are continuous and are going to become the renal tubule cells. So the whole tubule is made of epithelial cells. And then on the inside, we have the capillaries. So these are the glomerular capillaries. Next to the capillaries, these are called the podocytes. Anybody remember what the podocytes do? A filtration barrier, exactly. So notice here, the podocyte is in purple or bluish, and these little these little slits, so they're called little slits, podocyte slits, they actually are all continuous with this cell. So these are processes, long arms of the cell that are on the outside of the capillaries within the urinary space to serve as a layer of filtration barrier. And then the other cell type you see here, these are the mesangial cells. So the mesangial cells are within the matrix of the glomerulus. They're continuous with the basement membrane. The basement membrane is around the layer of the capillaries. So remember, the endothelium is going to be your innermost layer of all blood vessels. And then right outside of the endothelium is the basement membrane. And you have a specialized type of basement membrane in the glomeruli to help with this filtration function. So there's basement membrane. And that basement membrane forms a network throughout the glomerulus that the mesangial cells live within. And the mesangial cells, along with the endothelial cells, help produce the basement membrane. They're kind of like fibroblasts. They can produce growth factors. They can secrete collagen. They can proliferate and initiate the repair process. So if there's chronic inflammation going on, they're going to be involved in that repair and scarring formation. So that's the job of these mesangial cells here, is really a supportive structural function for the glomerulus. So I want to get into a little bit more detail about that filtration barrier here. I'm just going to draw. So imagine we're taking a cross-section now in the other direction, and this is the epithelial cell. This is going to be the urinary space, or the filtrate space. And then down here, and I'm drawing the cell body to give you the idea that this is a cell. This is a capillary cell. So the capillary itself, those endothelial cells actually have big holes in them called fenestrae. Let's see. Well, let me do it. So basically you'd have little, imagine that there's little space here for fluid to come out from the blood. And you can see on this picture these holes depicted right there. So those are called the fenestrae. So the endothelium of the capillaries and the glomeruli are very specialized. You don't see fenestrae throughout all of your capillaries in all of your body. It's only in those glomerular capillaries. And then the next layer, now we have that basement membrane. And the basement membrane is a specialized form of connective tissue. It's really like a meshwork of collagen and other support proteins. So there's no cells in there. It's made by the mesangial cells and the endothelial cells. And it provides an electric charge. So it's got it's very electron dense within the glomerulus. Why is that important? So our filtration, this is our filtration unit. Filtration is based on size and charge. So the fenestrae let out all particles that are 70 nanometers and smaller. They're about 70 nanometers wide. And then there's an electron-dense layer in the basement membrane. So even if a particle is small, if it's very negative, it's going to be repelled, and it's not going to filter out. So it's repelling large negative molecules. And then our third layer here are these podocytes, the podocyte feet. And in between them are we call those filtration slits. So the space in between them are filtration slits. So there's 3 layers, right? First, particles have to get through the fenestrae, then they have to diffuse through the basement membrane, and then they have to get through the filtration slits of the podocytes. So we have 3 layers to make sure that we only let through particles of the right size and charge. Here's a normal glomerulus on histology. See if, now that we've talked about the different structural features, see if you can match up each of these terms with what you see in this slide. So every arrow will match with one of these terms. And you can work with your group or your neighbors. So, mechanisms of glomerular injury. For primary glomerular disease, the mechanism is almost always immune-mediated. It can be immune complex. And remember, immune complex is what type of hypersensitivity? Type 2. So it's antibodies binding to antigen as they're circulating in the body, and then they get deposited. And they can get deposited in blood vessels anywhere throughout the body. And if they're deposited in the blood vessels of the glomerulus, then they're going to cause glomerular disease. And they're more likely to be deposited in the glomerulus than other places in the body because it filters so much blood, and you have those large fenestrae of the capillaries, so these immune complexes can actually get through the capillary wall and deposit in the glomerulus itself. And then you can also have antibody-mediated, which is the type 3 hypersensitivity, where you produce antibodies, and those antibodies bind to antigens within the glomerulus. So the antibodies in the glomerulus, they could be either normal proteins of that glomerular structure, or they might be, like if in post-streptococcal glomerulonephritis, there's microbial antigens get deposited in the glomerulus itself, and then antibodies bind to that, and they get trapped there. And then with secondary glomerular diseases, they're often also immunologically mediated. But you can also have vascular or metabolic, as in diabetes or hypertension. And this picture over here is showing focal segmental glomerular sclerosis. And you can see here that all of this extra dense pink is sclerosis. It's scar tissue. It's extra collagen that's been laid down as the mesangial cells have been activated because of an immune-mediated process. Here's a little diagram. This is from your book, so you can go into your book and look at it if you want to a little bit more. What I was talking about over here, the immune complex deposition, type 2. So these are immune complexes. Again, the antibodies and antigens bind to each other within the circulating blood, and then they pass through the fenestrae and they get deposited. Most of the time, it's subendothelial. So they get deposited right underneath that endothelium, and then they can't get through the basement membrane. That's usually what you'll see with immune complex. With anti-glomerular basement membrane, which is good pasture, or any other antibody that's binding to an antigen within the normal cells of the glomerulus, you see this nice linear pattern here. The antibodies actually are getting into the basement membrane, and they recognize an antigen in the basement membrane as foreign, and they're binding to it there. And then there's some antibodies that actually recognize podocyte antigens, and they can cause damage to the podocytes. And why that's important is if you are looking, if a pathologist is trying to figure out what type of disease a person has, they'll often look at a pattern of staining. So here we're staining antibodies. Remember how we talked about you can put a fluorescent tag and actually look to see if you have IgAs or IgGs present? So in immune complex deposition, here they're looking for IgGs, and this pattern is called a granular pattern. So do you kind of see how it looks almost like punctate, little dots making up this pattern, compared to over here, this smooth, what's referred to as a linear pattern. And this, if you go back, this is somebody with good pastures with anti-glomerular basement membrane disease. So those are the two patterns that pathologists look for to try to differentiate what's going on. And we've already mentioned this, so here's good pasture syndrome again. It's a linear pattern of staining, and this is type 3 hypersensitivity because you're actually producing antibodies that bind to proteins in the basement membrane. With good pasture syndrome, the basement membrane protein antigen that these antibodies happen to recognize is also found in the basement membrane of the lungs. So people with good pasture will have both lung and kidney disease. So knowing this, knowing these antibody deposition, whether it's immune complex or in situ antibody deposition, is underlying glomerular injury, what do you think is the mechanism? I'll give you a minute to talk to each other about it. So we have antibodies, and they can activate complement. Or they can activate macrophages. And then complement can activate those macrophages. So basically, they provide the stimulus for inflammation. Now, we're going to recruit neutrophils. You can cause, when those inflammatory cells come into the area, we get what's called bystander necrosis. So they think that there's something bad going on. They think that there's a pathogen around. And so these neutrophils and macrophages start to release reactive oxygen species, lytic enzymes to try to kill the bacteria or the pathogen that they think is there. Of course, in this case, it's only antibodies around. There's not actually a pathogen. And so you get necrosis of the surrounding tissue as a collateral damage effect. For some reason that I can't quite explain, sometimes you actually activate complement, and that complement can directly cause necrosis of the podocytes or the endothelium without inducing an inflammatory response. So without a lot of cells, without the macrophages and neutrophils coming in, you can still get necrosis because of these antibodies. And it's important to understand that when we talk about the clinical syndromes associated with glomerular damage. But the damage is really occurring because of either complement or leukocytes from inflammation. Either way, you're going to cause damage to the glomerulus. Now, people who have some kind of damage to the glomerulus are going to present in two different ways. So these are called clinical syndromes, and we call them the nephrotic syndrome or the nephritic syndrome. And they have different symptoms associated with it. Both are the result of glomerular damage, but with nephrotic syndrome, the biggest thing I think of is generalized edema. And the way I remember that is with nephrotic, it's big O enlarged. With nephritic, it's thin. So they actually don't get a lot of edema. They get a little bit of edema with nephritic syndrome, but nephrotic syndrome, if you see somebody with nephrotic syndrome, that pretibial edema you saw with right heart failure, you'll see that same thing with nephrotic syndrome. So generalized edema. These people they can gain 30 pounds of water just because of this glomerular damage. And that's because they have massive proteinuria. The damage that's caused in nephrotic syndrome causes proteins to leak. So most of the time, nephrotic syndrome ends up being damage to podocytes and also the epithelium, or endothelium, sorry, which allows protein to leak into the filtrate. Lots and lots of protein. As that protein leaves the blood and they end up peeing out their protein, now you've lost the osmotic pressure in the blood in the rest of the body. So low protein in the blood causes that osmotic pressure to go down. So often remember that osmotic pressure is holding water in the blood vessel, whereas hydrostatic pressure pushes it out. Now you don't have as much osmotic pressure, and fluid leaks out of the blood vessel in the whole body. So that's how the proteinuria leads to generalized edema. Hypoalbuminuria, albuminemia, sorry. Albumin is the main protein in the blood. It's a carrier protein for ions, and it's produced by the liver. And one of its most important functions is that osmotic pressure. So as you lose protein in the urine, albumin in the blood goes down. And then the mechanism by which these people also have hyperlipidemia is not completely understood. But often you'll see that they have high cholesterol and high triglycerides in association with it. And that's in contrast with nephritic syndrome. So people with glomerular damage that don't have a lot of proteinuria and a lot of generalized edema have nephritic syndrome. Usually you'll see hematuria, red blood cells in the blood. Oliguria is the biggest clinical symptom. People usually present with hematuria and oliguria. I'm not making much urine. I found a little bit of blood in my urine. And then when you do blood tests, you realize that they have azotemia, high blood urea nitrogen levels. And frequently, they have hypertension, probably because the kidney damage causes dysregulation of the renin-angiotensin system. So nephrotic syndrome, the one thing that people with nephrotic syndrome tend to have is podocyte injury. So those filtration slits by the podocyte feet really serve an important purpose in protein filtration. So this allows protein to filter out. However, they don't have as much inflammation. So inflammation causes more endothelial damage, and that's where you get the blood, like you see in nephritic syndrome, whereas nephrotic syndrome, it's mostly just that podocyte injury that's causing protein to filter out of the blood, but red blood cells don't filter out. Now, there's a lot of different diseases that can cause nephrotic syndrome. These minimal change, focal segmental glomerulosclerosis, and membranous nephropathy, these are all primary glomerular diseases, whereas diabetes and lupus are secondary. I don't want you to memorize all of the glomerular diseases and all of the differences. Your book goes into detail about each of them. When I learned it, I found it completely overwhelming. Right now, just focus on the mechanism and the difference between nephrotic and nephritic syndrome, and the main mechanism of immune-mediated dysfunction of the glomerulus. So this is to show you with nephrotic syndrome, minimal change disease is one of the major causes, especially in children. We don't know why it happens, but sometimes you'll have kids coming into the hospital and they're just, all of a sudden, they gained 20 pounds in the past week, and it's all fluid. So and then you measure their urine and you find massive protein, their blood has low albumin, and if you look under the light microscope, you don't see anything. It's not until you do electron microscopy that you see this is podocyte effacement. And what you can see is that those filtration slits have been lost. So these podocytes, they kind of merge. They don't form these nice slits anymore. And so some areas are completely blocked, and then other areas are completely wide open. So you've lost that fine filtration, and that's what allows the protein to escape. Here's another example, membranous nephropathy, and you can see that there are in electron microscopy, these deposits within the podocytes. So again, we have podocyte damage. These are antibodies called subepithelial deposits. So we're causing podocyte damage. Nephritic syndrome usually involves inflammation. So that inflammation, on microscopy, you're going to see a lot of inflammatory cells. Notice if I go back here. So again, you don't have to memorize the different diseases, but you should understand their mechanism. So on the exam, you might expect a question where I'll tell you, minimal change disease is caused by such and such. So what do you think is the primary mechanism underlying that? Or what do you expect to see clinically in that patient? So if you just understand nephritic and nephrotic syndrome, you don't have to memorize all the different diseases. You'll come to that later. So here's post-streptococcal glomerulonephritis. I thought I had my phone go off on, I was going to have it tell me when it was time for a break, but it feels like there's no time. Yeah, it didn't. Oh, it did go off. I just didn't notice it. Okay, push on. 3 minutes. Post-streptococcal glomerulonephritis. So what you can see here is that granular pattern. So we have subendothelial deposits of antigen antibodies. And over here, you see that there's a lot more cells around. And this isn't even a great example. Sometimes you'll see a ton of cells in the area, but the main point to see here is increased cellularity. And the reason you see that is because those antibodies are triggering inflammatory cells to come into the area. Same thing here with IgA nephropathy. Notice you can see a lot of increased cells in the area. And a lot of those are the immune cells being activated by those IgA antibodies that are deposited in the area. So the last clinical syndrome with glomerular disease is rapidly progressive glomerulonephritis. And this is really a subset of nephritic syndrome. It just happens much quicker than you normally see with other types of nephritic syndrome. So it can have the same underlying causes. It can be anti-glomerular basement membrane, immune complex, and then there's a few times where you see it and you don't see any antibodies deposited, and they don't really understand what's going on there, so they just call it pauci-immune. It means there's not any immune cells, something else is triggering it. But basically, the patient presents with oliguria, renal failure, because of that low glomerular filtration rate within weeks. So that's why it's rapidly progressive. With nephritic and nephrotic syndrome, normally you have time, you can figure out what's going on. The person will present early in the course of the disease. But with rapidly progressive, it just happens so fast, it's hard to catch. Okay, I'm going to pick up on Thursday with tubulointerstitial nephritis.